Just 1 minute.
Dr. Prashant, you can start your session.
Okay, thank you. Sir, we can start.
Good afternoon, everyone. I am Dr. Rafi, Chief Consultant Pulmonologist from KIMS Hospital, Gachibowli, Hyderabad. So today, from the very seasonal issue of viral viral infections, which is flu, which is troubling a lot of people, we're looking at how the actually medication what we regularly use is been impacting in the clinical practice. So I thank Hetero Healthcare to be coming up with this very successful antiviral medication. So without any delay, I think we can just jump into the slides and then see a bit of how it is done. When we are looking at Oseltamivir, which is empirically using in the flu management, so earliest is the best way to start rather than delaying it too far. That's how we practiced even in the post-COVID era and then pre as well. When we see the healthcare challenges in the monsoon and the diagnosis, so typically the monsoon season starts at July and then extends up to like late August, September, and then subsequently you might have a brief lull period, and then you usually have a winter season as well. So this whole almost about 4 to 6 months of the time, basically, typically in a tropical country like us, we'll encounter looking at the flu season on and off. So off late, what we see is the flu season is an on and off, not like in a single stretch for the longer period of time. So what healthcare challenges when we're dealing with it, looking at in the monsoons, this typically what we get infected, what we've seen is the regular flu influenza, which is A strain, and then you have a little more stronger strains like swine flu, and then the corona, which is, and also the rarely we have seen other viruses also troubling. Briefly, what we're looking at is some clinical evidence of where oseltamivir being properly used. Guidelines, recommendations, what does that tell about the empirical use? So this term has been coined like influenza-like illness, which has been like more often even before the actually established flu. So just the runny nose, a little bit of a sneezing, and then stuffy nose, but like not actually at the level where like full-fledged body ache, severe fever. So these symptoms also we can say which is influenza-like illness. And then when you look at it clearly, H1N1 has troubled a decade back a lot, and subsequently when we have a once in a century kind of coronavirus as well. At times you have this severe acute respiratory illness, whereas a simple flu can turn into pushing the less fortunate who have the immunity being low, or the strain is probably amalgamated of above strains or a stronger strain of that season, impacting with the comorbid conditions like usually the severe acute respiratory illness. We also seen in the young adults as well, and also a pediatric age group, especially they are vulnerable as well. The less said is the better, and then you knew it with the waves and all, COVID-19 as well. So year-wise number of cases, when you look at it, and then the deaths from 2017 to 2022, there is data shows like there is a decreasing trend in the deaths when you see the 2000 plus in the 2017 out of 40,000, close to 40,000, and then almost half, 40% of cases have been seen, diagnosed, and then about 1,000 deaths. And in 2019, again, there's a spike, and then 1,219, 2020, when it comes. So the deaths have been with the seasonal flu, like H1N1, year-wise numbers have been brought down significantly. When you see this, the more and more you have to contribute it towards the usage of oseltamivir. So when you look at the overall when you look at the overall overview of influenza flu in India, so the cases of influenza infection, incidence of influenza-related deaths increasing alarmingly in India between 2015 to 2019. So when we look at the types of influenza viruses, here we have influenza A, B, and C. Usually A causes frequent epidemics due to minor antigenic variation and periodic pandemics due to major antigenic. You can say it's more of a shift than a drift. Influenza B viruses infects only humans, cause local epidemics. Influenza C infects humans and swine. Influenza type C infections generally cause a mild respiratory illness and are not thought to cause epidemics. Currently circulating in humans are subtypes of A, which are like H1N1, and then A with H3N2. H3N2 has been a recent past, has had more a pickup of strains when we do the panels in the ICU or the patients who have been admitted. Transmission of flu viruses, people with flu can spread to others about 6 feet away. So when you see the bacterial versus flu needs, even the longer distance, it travels easily because it's virus. Bacterial is a shorter distance where it has to be exposed. And then flu viruses are spread mainly by droplets. When people with flu cough, sneeze, or talk, these droplets can land in the mouths or noses of the people who are nearby or possibly be inhaled into the lungs. People should stay away from the affected person, stay home if sick. Important to wash off hands with soap water. And then these are like a simple measures we have been adopting. Off lately with general awareness has been increased, as you can see with the more and more viral infection we have been dealt with. Most healthy adults may be able to infect other people beginning day 1 before symptoms develop up to 5 to 7 days after becoming 60. What is here, the catch is even before, because he's healthy, he holds on up to at least about 72 hours to before showing the symptoms. But I think he's ready to infect about in the first day itself. So children may pass the virus for longer than 7 days, usually 2 weeks. Symptomatic differentiation of, influenza-like illness. I mentioned this initially, H1N1, SARS, and then COVID-19. When you see influenza-like illness, fever is there, myalgia is there, cough is there, lack of energy. But I think breathlessness may or may not. Loss of smell, loss of taste, no. Diarrhea, no. Headache may or may not. So, it doesn't have a whole gamut of symptoms. So where you see a COVID-19, it has checking all the boxes. Headache is sometimes. I think nowadays we see, because a coexisting sinuses, probably headache as well. SARS has like a little bit of may or may not headache. So almost similar, but loss of smell is not specific to it. And diarrhea is not specific to it. And comes to H1N1 as well, it's the same. Breathlessness, I think all these 3 flus are stronger ones which can cause the breathlessness, like H1N1, SARS, and COVID. But influenza-like illnesses should not cause actual breathlessness. Emergency warning signs of flu sickness, especially when you see the adults, difficulty breathing or shortness of breath, pain or pressure in the chest or abdomen, sudden dizziness, confusion, severe or persistent vomiting, flu-like symptoms that improve, but then return with the fever or worse cough. So usually they get into the phase where like they have a immunity fighting it out, and then actually virus taking a little over, and then some receiving symptoms and then coming back. Happens in the adults. Where in the children, fast breathing, bluish skin color, they are getting dehydrated, not taking fluids, very irritable, doesn't want to be held. Flu-like symptoms improve, but they return with the fever with the worst cough, similar. Fever with rash. These are like skin-related symptoms also show up very quickly in the children. And in addition to the sign, in an infant, really little ones, being unable to eat, trouble breathing, no tears while crying, that's a dehydration sign. Fewer diapers than normal. So this is like indirect measures where you can see the child is actually dehydrated. Complications, when the bacteria gets in, once the denudation of the epithelial layer with the viral infection, I think bacterial infection gets in, as a secondarily, that is pneumonia causing pneumonia. Bronchitis is something which is like chronically inflamed epithelium kind of persons who have been exposed to the allergens or post-viral infection bronchitis. Ear infection, it can spread to, and then worsening or existing diseases like asthma, COPD. I think pre-existing diseases with the respiratory system are already there. I think that can worsen very quickly. ARDS is something which we are looking at. I think we mentioned really getting into the respiratory failure with the breathlessness and then the oxidation hypoxemia conditions. Death is something which is also a complication. I mean, not to scare people, but I think simple flu can lead to that far. Treatment of influenza is mostly like whatever the flus are, like 85% of the patients actually should recover with a minimal support, whereas 15% of the people who we are playing with, where they are getting really troubled. Largely bed rest, increased fluid consumption, cough suppressants, antipyretics, analgesics as paracetamol, non-steroidal anti-inflammatory drugs or fever or myalgia. Most patients with influenza recover in 3 days. However, malaise may persist for weeks. We have seen this symptom. A lot of people saying about, like, especially with the comorbid conditions and then coming back recovered, but they still be having these symptoms for persisting for a longer period of time. Severe cases may require intravenous hydration, other supportive measures, and then treatment with antiviral drugs. Neuraminidase inhibitors block the viral neuraminidase enzyme, which is critical in releasing the virions from the infected host cell. So this is the basic mechanism with the neuraminidase inhibitors work. These drugs are active against the influenza A and B. The examples, I think we're talking about that drug, Oseltamivir, Oseltamivir. Adamantans like M2 ion channel blockers, these interfere with the hydrogen ion channel activity of the influenza A virus, thus blocking its entry into the host cell. So this one, the second M2 ion channel blockers prevent the virus getting in, whereas the host cell response has been actually critical when you're using the Oseltamivir. Active only against the influenza A viruses. Amantadine, rimantadine are the drugs. Let's look at Oseltamivir, potent and selective inhibitor of the neuraminidase enzyme of the influenza viruses A and B. It's a prodrug, which is converted to the active form with the carboxylate in the liver. Inhibits influenza virus replication and pathogenicity. Pathogenicity prevents further spread of infection. It is effective against all strains of influenza A and B, including the avian H5N1, swine origin H1N1, and H9N2. These are the little bit of remote strains sometimes, because usually flu infections nowadays is a compendium of a combination, conglomerate of multiple viruses rather than a single infection. That is what the new era of treatments, what we are looking at. Oseltamivir. This is the image which is showing the host cell budding virus. Neuraminidase cleaves the receptor so that receptor contains sialic acid, and then virion doesn't release the new virions. So it kind of blocks it. Neuraminidase inhibitor actually blocks this area. Okay, so let's look at the first oral neuraminidase inhibitor. Also FDA, CDC, American Academy of Pediatrics. So usually pretty safe in using pediatric populations as well, has been approved by all the bodies which give the clearances for the drugs, where we can see Oseltamivir dosage and recommendations. Briefly to look at how the dosages. Adults 75 milligrams capsule twice daily. If you're giving a chemoprophylaxis, especially we give at ICU admitted patients as well, because once a day it can be given for 10 days. Children weighing less than 15 is 60 mg per day divided daily, 30 mg once daily, 2.5 ml, 15 to 23, 90 milligrams per day divided twice daily, 45 milligrams once daily, 3.75 ml, 23 to 40. I think weight-based importance is more with the pediatric age group when you see this chart. Infants, I think 0.25 ml per kg. So it's technically, infants is something where very little dosage you would expect it to give, and then also a judicious decision rather before taking it. benefits of empirical and early use of Oseltamivir. A lot of clinical trials have looked at it. I think in the practice, as we clinicians also have looked at a lot of benefit giving empirically when the patient actually, if you have very strong suspicion and then you're sure of it, that point of time, looking at one of the prospective study, treatment of influenza illness reduces the LRTC's antibiotic use and hospitalization. So hospitalization, antibiotic use, secondary antibiotic use, all that is mitigated when you start the antiviral, when you're looking at the seasonal infections. I told you about the spectrum and the thicker the times when we are facing this. Right now, we are in the midst of it as well. Data on LRTCs and antibiotic use from almost 3,500 subjects ranging from 13 to 97 looked influenza-like illness enrolled in 10 placebo-controlled double-blind trial shows this 26% of the patients' antibiotic use has been reduced when you started a timely viral antiviral. Influenza-related LRTCs resulting in antibiotic therapy is reduced by 50%, hospitalizations reduced by 50% to more than close to 60 as well. So reducing occurrence and severity of pneumonia due to H1N1 by early Oseltamivir administration retrospectively, looking at about 400 plus patients, median time of symptoms onset of Oseltamivir administration was 5 days. But I think a smart clinician should be able to pick it up in less than 72 hours, like if the patient approaches. Subjects were divided into 4 groups based on time to Oseltamivir administration, less than 2, 3 to 7, 8 to 14, more than 14. So all stretch times have been looked at. Both the probability of any severity of pneumonia and the probability of severe pneumonia increased gradually with the time from symptom onset to Oseltamivir administration. So earlier initiation has shown onset after the symptom onset significantly reduced the occurrence and severity of pneumonia and shortened the hospitalization due to the pandemic. When we see in 2009, even when administered 48 hours after symptom onset, showed a considerable potential for reducing the pneumonia. So I would say in my practice, actually about 3 days, 72 hours is the limit where you can immediately start without any hesitation if you have a significant suspicion. When you look at the guidelines, strongly recommended empiric, started as soon as possible. Laboratory confirmation of the influenza virus, not necessary. Negative lab test on the H1N1 doesn't exclude the diagnosis in the patients. At times, negative test doesn't exclude because of the mixed flu infections. Higher risk individuals have been exposed to a patient with influenza, consider presumptive treatment with Oseltamivir as well. Give empiric antimicrobials to treat all likely pathogens causing these empirical antibiotics should be based on the clinical diagnosis. Usually, I mean, secondarily, productive sputum, fever is more, and then productive cough, all those things gets into a picture where healthcare associated pneumonia, if infection was acquired in the healthcare setting, that is also there. Sepsis is something, all new gamut of things, but I think in the treatment plan, I think antiviral is also one. Empirical therapy includes neuraminidase inhibitor for treatment of influenza when there is local circulation and to or other risk factors. Travel history is the most significant one. What we're seeing, like a lot of travel these days is more air travel as well. Exposure to animal influenza virus have been mentioned. So depending on the clinical microbiological results, I think de-escalation should be done. In adults with CAP who test positive for influenza should treat regimen individual antiviral therapy. We recommend anti-influenza treatment such as Oseltamivir be prescribed for adults with CAP who test positive for influenza in the inpatient setting, independent to the duration of the illness after diagnosis. So a patient admitted into the hospital, probably it's the day of the illnesses, we are not able to track it because even before coming to the hospital, he might have had a little bit of leeway where he used just the over-the-counter and then he got more sick and then admitted into the hospital. Hospital admitted patients, obviously he's at more risk. So obviously there is no hesitancy of starting it if you have a suspicion and also as a proven. Several observational studies suggest that treatment of Oseltamivir with a reduced risk of death in patient hospitalized with community acquired pneumonia who test positive for influenza virus. Within 2 days of the symptom onset or hospitalization may result in the best outcomes. Up to benefit maybe 4 to 5 days. I said like best would be about 3 days and then 4 to 5 days also after symptom begin. When you look at the summary, proper diagnosis and early treatment can prevent flu complications. Empiric use of oseltamivir reduces lower respiratory tract complications, hospitalization, antibiotic use. WHO, American Thoracic Society, MOHFW recommends empiric use of oseltamivir. Has incidence of viral infections increased? So at this point in time, I would like to see like what usually the clinicians, like today we don't have a panel, but I think as we see in the usually what the questions we usually throw into the panel, where a lot of clinicians might be having in their mind, we are thinking about that and then we kept it. We have Dr. Prashant here.
Yes, sir.
So couple of questions, I think if you want to.
Yes, sir. Sir, do you think that, actually speaking, the major thing with general practitioners is that how to differentiate between a viral infection and a bacterial infection clinically? Is there something that can give them a hint or guideline, something like that?
So bacterial infection, something which is like patient would start having a productive sputum.
Okay.
The moment like when he's saying like common symptoms between the viral and bacterial would be usually like they start off with the same like cough, cold, body aches, headache,
Okay.
malaise. But I think clearly distinguishing more productive sputum, getting into the zone where it is altered sputum is something which is pushing it towards the bacterial. And then we have not tested, but I think this is the initial symptom we can say.
So do you think the incidence of viral infections has increased over a period of time as compared to yesteryears?
I think, as I mentioned as I'm running through my slides, uh, we are seeing now more of a combination of flu viruses. When we do send a panel, if we are sending a panel, I think you tend to pick up in these
Yeah,
seasonal infections
correct.
more than
Yeah.
one type of viruses as well. So it is increasing.
Sir, how long you have been using this oseltamivir?
Yeah, way back when we had a swine flu time,
Yeah.
it has, I think, since almost a decade long, I think we've been using Oseltamivir. I think it has definitely helped with the patients who we picked up early.
And sir, I mean, any major adverse effects that you have seen with this drug?
Um, there are no major adverse effects. It's even in the pediatric age group, it is pretty easily tolerated. At times, a bit of little, gut
Huh. GI
motility
upsets.
issues, GI effects can be expected
Yeah.
as such with any other medication.
Yeah,
But
yeah,
other than
correct.
that, I don't see any untoward, any specific adverse event.
And in most of these cases, you have started empirically or after test?
Um, See, the point earlier during the season of the pandemics, more testing has happened.
Correct.
And then post that, what I am seeing is these patients be able to accept the doctor's advice as well, what I am seeing as a clinician
Correct.
advice. So if they are trusting the judgment of the clinician, where when you suggest, I think they're taking, I think more of a hospitalized patients testing is more. As an
Correct.
OPD patients testing, I think I'm seeing not being like when we did in the COVID or even the swine flu times.
So empirical use is also recommended by like the
Recommended.
WHO or other bodies.
Yes, definitely.
And generally will prescribe for 10 days as for prevention and treatment 5 days generally.
Yes, absolutely. You are right, Dr. Prashant.
And sir, your overall experience with oseltamivir, take home message. I mean, that's what is needed by our doctors, with the experience of our practicing doctors.
Yeah. So overall experience with the oseltamivir is my practice. I would say that in the new age viral infections, when you're looking at it, I also have two just brief cases as well we can go through.
Okay.
But I think I just want to tell this point. 48 to 72 hours is the timeline where even the clinician of the start of the symptoms, even before the start of the symptoms in the healthy adults, we said. But I think that
Ah,
to picking it up, it's a little difficult. But I
yeah.
think any symptom starting between 48 to 72 hours, you would be able to have a very good advantage of starting the empirical treatment without even testing, especially the more stable phase of the patient who usually walks into the OPD clinic where you can actually suggest this zone. Usually prolonged period of time, more than a week, what we are seeing, especially if the patient probably recovers through by himself or through actually with the comorbid conditions would go into a hospital admission or something where you would want to give it a prolonged period of time as well. But late starting the oseltamivir, what we have seen is the advantage is little less, but early before 72 hours is the best time.
If you have any cases, sir, we can definitely discuss.
Yeah, just I think let's see quickly one
Yeah,
case.
Yeah.
I just I think jumped back the slide before
No
the
problem,
question.
sir. No problem. No problem.
So when you see this is a pediatric case when see like almost 6.5 years child immunized for routine childhood vaccinations presented with fever 103, 104. I think in the children the fevers are high. Cough and cold for 2 days, throat pain 1 day, breathlessness few hours. Here, important point, look at his breathlessness few hours, no significant past family history, well nourished, febrile, mild tachypnea, respiratory is 40. I mean, mind you, children respiratory rate is usually a bit slightly higher than adults. Heart rate is high as well, 150, BP is 90/60. I think a slightly dehydrated to probably hypovolemic, SpO2 93, 94 on a room air. Throat congested, nasal discharge, watery, chest bilateral creps already, rest all looks okay. Investigations we did, hemoglobin is all right, 11.9, TLC is normal range technically, or lower normal. When you see the lymphocytes, I think significantly 20%, neutrophil 65%. CRP is also normal here. Chest X-ray, bilateral perihilar opacities, bronchovascular markings. Considering above findings and sick child, respiratory multiplex PCR was sent, which was positive for H1N1. So the key point, what I've seen with this case is a little bit of CRP is not raised, and then doesn't seem like really a bacterial kind pickup with the counts going up. Child was started on a IV fluid, oxygen inhalation with nasal cannula. Oseltamivir syrup has been started. Child continued to have high-grade fevers next 24 hours, paracetamol infusion. After 24 hours, fever spikes started declining. Respiratory distress settled. Child gradually weaned off from oxygen. 72 hours, child was afebrile. No respiratory distress. Cough persisted. Cough persisted. Child was discharged on oral oseltamivir, decongestant and restful. Cough suppressant. So this is actually highlights the rapid progression of the disease and rapid recovery as well when you do a proper diagnosis and then prompt antiviral therapy. So let's look at the second case quickly. It's like a slightly elder, child 10-year-old seizure disorder. He's already on a anti-seizure medication, persistent fever, cough, persistent cough for 3 days, fever for 3 days, 102, 103, weakness, body ache, heaviness of the chest, one episode of stiffness, both upper limb and rolling of the eye, very transient. So a febrile seizure you can think of, and then he's also a known seizure patient. Child was admitted in emergency. Weight is okay, 33, 137 centimeters, temperature 101, pulse 137. You see the saturations are okay, 98. BP is also maintaining. Respiratory distress not to be seen. Conscious oriented abnormal movement, no abnormal movements. Throat grossly congested. Conducted sounds are there. CNS and other looks no abnormality. CRP is slightly raised. You can say perihilar prominence is there. Fanal is signs of influenza B. So X-ray also you can see the perihilar congestion here. So here influenza complicated by underlying comorbid conditions. That is what it is, because even though it is not looking like very high febrile or saturation dipping, but still this patient also had proven to be influenza. So different cases, but I think the response with the medications are quicker. So Dr. Prashant, I would, if you want to have any question, yeah.
No, sir, thank you. I mean, we have already discussed this. Thank you so
Right.
much. Yeah,
Yeah.
you can
So-
stop sharing. And
Yeah.
once again, thanks, sir, for taking time and addressing our doctors for whom this clinical experience is more important than the academic papers. I mean, the trust of our own doctors is more important. And thanks all the doctors who took time from their schedule and attended this. Thanks, marketing and sales team of Hydro.
Sir,
Thank
excuse
you.
me.
Sir, you can sign off, sir. Yeah.
Thank you.
Sir, excuse me.
Yeah.
So there was one question from the audience that can it be used in the elders?
Yeah, absolutely. So there is no restriction on that part. So only thing you could say when you're using with the H1N1 elderly, so usually they'll be having a diabetic as well at times when you're looking at the elderly patients where you don't want to use it if it is a specifically H1N1 kind of patients and any addendum steroids. So that is you need to be very careful. But I think other than that, Oseltamivir has no objection in using the elderly as well. I hope that.
Yes, sir.
Thanks,
Thank
sir.
you.
Yes, yes, yes. Thank you, sir.
Thank you very much.
Thank you for having me.
Thank you,
And
sir. Thank you so much.
thank
Thank
you.
you.
Kind of you.
So you can sign off, sir. Thank you.
Yeah. Yes, I.
Thanks, Sanjana.